Hello everyone. My name is Deniz Can Guven. I'm a medical oncologist from Turkey and an editorial fellow in the Journal of Immunotherapy and Precision Oncology. In this interview, we have the privilege of having Dr. Samer Srour, and today we are going to talk about their recent review published in the JIPO. The title of their review was the Chimeric Antigen Receptor T-cell Therapy for Solid Tumors, the Past and the Future. Before we start, I would like to thank Dr. Srour for his time today and spending time with us for this interview. So welcome, Dr. Srour.
Thanks, Dr. Guven, for the introduction and giving us this opportunity to go over this review, Chimeric Antigen Receptor for Solid Tumors, the Past and the Future.
So thank you very much for being with us today. Before we start, I would like to introduce you and your current position to our audience. And Dr. Srour is an assistant professor of medicine in the MD Anderson Cancer Center, Department of Stem Cell Transplantation and Cellular Therapy, and he has a particular interest in the CAR T therapy in solid tumors and also in their unit, he's currently working on carrying on the experience with CAR T therapies from hematologic tumors and solid tumors. And actually, I benefited from their review significantly. And before we start, I would like to thank both him and also Dr. Serkan Akın for sharing this review with the JIPO. And to dive the review further, I would like to ask 3 questions about Dr. Srour's opinions on how the field could move forward in the following years. My first question would be, do you expect a more tumor agnostic developments in CAR T therapies in solid tumors, or rather the advances will be with clinical trials enrolling patients with individual tumor types?
Yes. Again, we have learned over the past few years several lessons. First, from our experience in heme malignancies, the CAR T cell therapy has, right now it's a new standard of care for several of these high-risk hematologic malignancies. After like decades of work in the CAR T cell field, from the preclinical to the clinical, and after multiple failures, we finally got the FDA approval in 2017 in large B-cell lymphoma. And since then, we have right now over 6-7 CAR T cell therapy approvals in different indications. And in the solid tumors, we are unfortunately still behind to make a change in the practice, which means like to get FDA-approved products in the solid tumors. But we have a lot of data generated from positive and negative studies in solid tumors over the last, I would say, more so over the last 10 years, but that started even 20 years ago. And we have kind of proof of concept from these previous studies, clinical and preclinical studies, solid tumors, that CAR T cell therapy works for solid tumors. It just has to be fine-tuned and modified to meet certain specifics for each maybe solid tumor subtype, and to counteract some of the suppressive tumor microenvironment and some other resistant mechanisms that we see in solid tumors we don't see in the heme malignancies. So I think the field is moving forward quickly. We are identifying every day new targets that may be more specific to this tumor versus that tumor. We are improving our CAR T cell therapy designs, and the figure 1 here that you just showed, we have right now 5 different generation of the CAR T cell constructs, and just the list continues to grow with newer modifications. And all these are meant to be, all the currently FDA-approved products in heme malignancies are second-generation CAR T cell therapies. Seeing here 5 different generations, and again, the list continues to grow. all these are meant to improve the field, particularly in the solid tumors, to overcome some of the resistant mechanisms. So I do think in the coming few years, we will continue to see, we already have, and we'll continue to see increased number of new clinical trials for different targets with different CAR T-cell constructs, and maybe with or without other combination strategies to improve the CAR T-cell therapy in solid tumors, and hopefully we can get some practice-changing studies soon.
So thank you very much for this comprehensive answer. So I would like to move further to the combination strategies, and you discussed truly the combination strategies in the review. So so I would like to ask your perspectives about what are the possible combination strategies with CAR T cells in solid tumors, and what will be the possible limitations and hurdles in the process?
Very questions, and a difficult question to answer because, you know, generally speaking, combination strategies, when you combine any other treatment or any other agent, whether to improve the efficacy of the CAR T cell, in other words, to improve its own expansion persistence for the CAR T cell product, or synergize the efficacy, tumor activity, and then you add to the CAR T cell. Anytime we do that, there's many challenges we have to keep in mind. It's not an easy thing to do. You know, in other words, if you add a combination strategy before the CAR T cell to the lymphodepletion, the question how this will affect the CAR T cell construct itself when you give it, and how that will affect also the patient, him or herself, toxicity-wise. If you add also after the CAR T cell, you add certain agents either to enhance the CAR T cell product, which some common things have been done in the past and still being done right now when you use cytokine therapy after the CAR T cell, for instance, IL-2 treatment. Okay, that might improve the efficacy of the product, but might also make your CAR T cell a bit more complicated to give to the patients, and the patients definitely would have more toxicities. So there's different potential combination strategies if you want to adapt it, either to include into the lymphodepletion to enhance it, or to include after the CAR T cell to enhance the CAR T cell activity in vivo after that. But my own preference would be how can we improve the CAR T cell constructs themselves without really another additional in vivo interventions, combination in vivo. Can we do it ex vivo in the construct itself to help the CAR T cell product improve its efficacy, persistence, expansion, and infiltration to the tumors without the need to add additional agents, which can has definitely side effects on the patients. This diagram here that you show, figure 2, actually shows different mechanisms or barriers why the CAR T cell don't work very well in the solid tumors so far. And based on this diagram, here we listed just 4 big groups. One of them is tumor antigen specificity. The second one is trafficking in the tumor tissue. The third one, tumor microenvironment, and the fourth one, toxicity. Can we come up with a construct to overcome some or all these resistant mechanisms without the need of adding new combination strategies? I think we have good data, preclinical, and some of it made it to the clinic, that we can do some of this ex vivo without the need to add some additional treatments, which can carry some toxicity to the patient. Tumor antigen specificity, that's a work in progress. We will continue to work on that. The best to find tumor antigen that highly specific to the tumor with low or no expression on the normal tissues. And then the tumor microenvironment, there are several attempts. One of the studies we have right now, for instance, it knocks out TGF-beta. TGF-beta is not one of the inhibitory factors in the tumor microenvironment. Can we knock out, for instance, the TGF-beta from the CAR construct, and then we can enhance the trafficking of the CAR to the tumor microenvironment, we can do that. Instead of using, for instance, chemokines or cytokines in vivo, there's also another way that you can have your CARs co-express functional chemokines. So we can do it ex vivo without the need of giving something in vivo. That way you can also enhance the trafficking of the CAR T-cell into the tumor microenvironment and tumor itself. And then with more specific targets, we can also eliminate or limit the on-target of tumor toxicity. So I think to answer your questions in short, yes, there are some combination strategies. For instance, people have used checkpoint inhibitors with actually, as I mentioned in my review, with like mixed results. There's no preclinically, yes, it might work, but in the limited experience in the clinic, it did not do a big difference in certain tumor subtypes. It might do it in different ones. And another way to combine with, for instance, adding radiation therapy. Radiation therapy has different mechanisms where it can enhance the CAR T-cell activity in certain tumor subtypes. And there's a long list of things you can combine with, but my own strategy is if we can do it without making it complicated, like the least complicated is the CAR T-cell therapy, the better for our patients. And that's our experience in heme malignancies. We don't, although people have tried, they try, but right now all the FDA-approved drugs, CAR constructs, are just single infusion with no other combination strategies. And when the patients respond, they're responding, they have durable responses. In lymphomas, we have now data for over 4 or 5 years, around 30% of the patients who responded, they're still like durable remissions. If we can get that without additional combination, that actually should be our first goal in improving the outcomes in solid tumors. And if we get to see some responses, but they're not sufficient, that's where we may have to add to that specific construct some combination strategies to see if we want to improve it without increasing the toxicity.
So thank you very much for this great answer also. So my last question will be actually a kind of provocative one. So based on the data that you summarize in table 2, do you expect a CAR T-based therapy to enter the clinical practice in the next 5 years in solid tumors?
Sure, I think the short answer is yes. If not in the coming 5 years, maybe the coming 5-10 years. Since we published this review a few months ago, and this table, we already, if I want to redo the review today, already add few more studies to this table. I mean, we have, like, again, as I said earlier, there's exponential rise of the number of clinical trials exploring different targets, different diseases, different even conditioning platforms, sometimes different combinations. The list just continues to grow. And we have seen in our own studies here at the University of Texas MD Anderson and in other studies published already either in abstract format or manuscript format, very encouraging results. We also have seen, as I mentioned in our review, the first historical FDA approval for TCR product in melanoma. So I believe, based on what we have seen so far and the clinical trials we have right now in progress, we will see in the coming 5 years or 5 to 10 years some breakthroughs in CAR T-cell therapy in solid tumors, which will be FDA approved and hopefully will make some durable remissions, if not cure, to some of the cancer subtypes in the solid tumor field.
So thank you very much for this answer also. So do you have any additional comments?
I would like to thank you again, Dr. Guven, for this interview with me to highlight this nice paper. I will recommend all the physicians or investigators who are interested in the CAR T-cell therapy solid tumors to go over this review. It's a nice summary about the CAR T-cell, also provides some comments or like brief section about the differences between CAR T-cell therapy, TILs, and the TCR. And we made it in a simple way where anyone can benefit from reading it, hopefully.
So thank you very much for your time, and also thank you very much for this great review. It was actually a great summary for a general medical oncologist like me, and also both the people who are familiar with the topic and not. So I would like to thank you again, and also thank the audience for having time for sparing their time for this interview. You could follow Jaipo on Twitter, YouTube, and LinkedIn. And have a nice day. Thank you.
Thanks, Deniz. Just want to also thank Dr. Serkan Akin, who really did a great job in putting this review with me. He actually did the initial search, and then me and him, we wrote this manuscript and revised it several times. So thanks very much for Dr. Akin also for his great contribution to this review paper.